All right, I think we can get started. Good morning, everyone, and welcome to the October session of the CBER Best Seminar series. My name is Sarah Burns, and I'm an event coordinator at the Odyssey Center, and I have the privilege to welcome you to today's seminar. Today's topic will be about what COVID-19 has taught us about surveillance. Before we dive into the seminar, I want to remind you of a couple of Zoom logistics. As you might notice, all lines are currently muted to help reduce background noise. The seminar will be recorded for those of you who aren't able to make it or want to share it with your colleagues. Now, if you want to ask questions, we do have Q&A functionality. You can use the Q&A chat at the bottom of Zoom, or you can submit questions through the chat box. I'll be monitoring both of these incoming methods, and you can post questions in the chat as well. We have time dedicated shortly after the presentation for Q&A. I'm so excited to be able to introduce today's speaker, Dr. Marc Lipsitch. He's an epidemiologist specializing in communicable disease, and we're delighted to have him from the Harvard T.H. Chan School of Public Health, where he joined the faculty in 1999. He's a professor in the Department of Epidemiology and the director at the Center of Communicable Disease Dynamics. In 2021, Marc was named Director for Science at the new Center for Forecasting and Outbreak Analytics at the US CDC. He is an internationally recognized expert in methods and disease transmission modeling, and he has been a leading scientific authority during the COVID-19 pandemic. Dr. Marc Lipsitch is an author on more than 350 peer-reviewed publications, and his research informs the use of transmission dynamic simulations to improve the design of randomized and observational studies of infectious disease interventions and bioethics related to infectious disease and clinical trials and emergencies. His recent COVID-19 research builds on 20 years of groundbreaking work on SARS, pandemic influenza, and other emerging infections. During the present pandemic, Dr. Lipsitch has been featured in thousands of press articles and media interviews from CNN and BBC to The Guardian and Wall Street Journal, and writes in and is interviewed regularly for outlets such as the New York Times and the Washington Post on COVID-19. Marc, I am so pleased to have you here today, and I'm really looking forward to hearing your perspectives. Without further ado, I'm going to turn it over to you to talk about COVID-19 surveillance.
Thank you very much, and thanks for the invitation to be here. I'm going to try to share my screen. Always the biggest challenge. I'm not finding. There we go. Good. Are the slides visible?
Yes, they are.
Great. All right. Well, again, thanks for the invitation to be here. I look forward to speaking to you for a few minutes and then having some time for discussion afterwards. Some disclosures on this slide, and just to emphasize that my views are given primarily in my academic role and are not necessarily those of any part of the US government. In the few months before, a few months before the pandemic of COVID-19 started, Mauricio Santillana, who's now at Northeastern actually, and I published this diagram in to try to lay out the reasons why surveillance needs to be done. And the idea was to motivate the types of surveillance and the ways that we analyze surveillance by reference to the kinds of questions in a pandemic in particular that they're aiming to help inform with evidence and data. So this came from work that had been done following the 2009 flu pandemic. I think it actually corresponds pretty well to the kinds of issues that arose in COVID-19 and continue to arise. Things like how big a response we should make, who we should target for direct and indirect protection with countermeasures like vaccines and drugs, how we should think about the balance between those two types of protection, slowing transmission versus trying to mitigate the severity of disease, when to scale up responses and when to scale them down. And to understand those questions and to answer them based on the best available evidence, we need to know things like how contagious the virus is, how severe it is per case, how that differs by host characteristics and viral characteristics and so on. And at the bottom are the building blocks that go into making those assessments and the kinds of analytic approaches that we can use to try to answer them. So all of that, as I said, was motivated by 2009 flu. I think we've learned a lot in the course of the last almost 3 years of COVID pandemic, and so it's now an opportunity to take stock and try to think about how we can do better in the future. One of the really striking observations in the COVID-19 pandemic is that that we rely on case counts, on numbers of positive tests, as one of our primary measures of disease burden. And it's important to understand when we're interpreting those data that that is not a natural quantity. And by natural quantity, I mean something that that is relatively immune to how you measure it and somehow intrinsic in the population. What I would describe as natural quantities are things like the incidence of new cases, new actual infections per day, the duration with which people stay infected, and therefore the prevalence of infection. And this funnel sort of describes the process by which we contaminate those relatively pure quantities with modifiers that vary in time, in space, and across strata of society. So with demography, and some of those are listed on the right-hand side. So this is the thing that we observe, the number of positive tests, is a hugely socially determined quantity, whose interpretation changes as there are swab shortages, as there are higher levels of concern leading to more testing, as people start to test at home, and so forth. And so one of the biggest challenges in the United States has been making sense of these case counts and trying to find alternative approaches to figuring out the burden of COVID-19. I'm going to argue for a relatively expansive definition of what surveillance should mean for us, and that's a newly formed view on my part, at least, informed by the experience of COVID. And the analogy I like to use is that of a Swiss Army knife, that we should not think of surveillance as a single activity, but really as a set of activities with different purposes and therefore different designs. Some of the most important purposes for surveillance are listed here, of detecting newly emerging viruses or viral variants, assessing individuals and figuring out potential treatments, characterizing severity of the infection and the effects of countermeasures. And one of the older, more classic notions of surveillance is understanding the changes in disease burden over space and time. So the first and last of these, I think, are very much seen by most people as surveillance goals. The middle ones, I think, are sort of more unconventional to put in the surveillance category, and I'll try to make the argument for them, especially the third one, as this talk goes along. So for each of those, we can talk about why we would want to know them and how we can know them. I won't go through all four of them, but focus on a couple of them, just for the sake of time and to keep things moving. So I think we all understand the need to detect new threats in a prompt fashion. And one of the most important reasons is so that we can activate the development of countermeasures such as drugs, diagnostics, and vaccines. the G7 and the Coalition for Epidemic Preparedness Innovations suggested in the last year or so the idea of a 100-day mission to have all of these available within 100 days of detection. If detection is late, that reduces the impact of even meeting the 100-day goal. So if you have a certain amount of time that it takes to develop these kinds of countermeasures, the sooner we detect, the sooner we can start to make an impact with our countermeasures. More recently, we've seen the issue of detection re-arise with the rise of COVID variants and the need to see when they are arriving in new populations or when they arise for the first time, even globally. What are the key characteristics of a system that's set up for detecting new threats? Well, one critical one is geographic scale. If you look at the first 4 variants that were detected, starting with alpha, which probably almost many of us can hardly remember because it was so long ago, and going through the early parts of the Greek alphabet, each of the first 4 was detected on a different continent. And so this could not have been a clearer demonstration of the need for geographic scale when we are, and international sharing when we are trying to detect new variants. Size is also important in the sense that the more we test, the more we're likely to find even rare variants of concern at a rapid pace. But importantly, the returns to scale are diminishing as we sequence more and more. And so if you gave me a choice between another 1,000 variants in the United States and say another 1,000 sequences in the United States and say 100 sequences in some country that is not sequencing, I would certainly pick the former over the new country over adding to our already large sequencing capacity. The rule of 3 is an idea that's been published about once a decade for the last 3 or 4 decades. We were among the more recent group to publish it in the context of surveillance for drug resistance in bacteria, but the same rule applies. And it's a very simple concept that if you want to detect a variant or a new thing at a frequency of 1%, you need to sequence 300 samples or characterize 300 samples. If you want to detect it at 0.1%, you need to test 3,000 samples. You always need to test 3 times as many as 1 over the frequency you're trying to detect. And so if we can decide as a society what level of sensitivity and early warning we want, we can calibrate our size to that. The other purpose of surveillance that I'll discuss in a little bit of detail is quantifying burden. And obviously there are a lot of reasons why we might want to do that. Just to have a general picture of the trends in the burden of illness so that we can plan to meet those needs. In order to understand the level of population immunity that may be there from natural infection, it's important to have an estimate of how many people have been infected to date. We want to quantify burden in order to evaluate control measures so that we know whether our control measures are working, and if not, where we need to intensify them, and if so, where we can perhaps relax them. Similarly, to identify hotspots where there may be particularly high needs, and demographic and other types of inequities, geographic inequities that may point us to needs for particular interventions. And I've shown some figures here that illustrate some of that. Here's a picture of the US at a particularly high point in transmission from the CDC COVID data tracker. Here's the unfortunately all too pervasive and well-known but remarkable disparities in impact by race and ethnicity, with American Indians and Alaska Natives and Hispanics at the very top, especially in the early part of 2021. Again, for Alaska Natives and American Indians in the end of 2021. And of course, it has gone on since then. Here is a figure from Luxembourg, which I'm going to talk about in a minute, because this illustrates this notion of tracking the prevalence of infection in a random sample, which I'll talk about more in a minute, and in correlating that with particular changes in the interventions and different waves of the virus. So how do we quantify the burden of disease? Well, one crucial aspect is representativeness. If we don't sample a representative part of the population, we can't really extrapolate to the rest of the population to estimate how many people are currently infected or have been previously infected with the virus. Luxembourg, for example, tested approximately 10% of its population every week at the height of its efforts. Whoa. Sorry, something just popped up on my screen that I have to get rid of. Sorry. And so they were able, through a relatively agreeable population and through very large numbers, to get a representative sample and to account for the areas in which it was non-representative. I'll talk more about the value of random sampling in a minute, but another value here was data completeness, so that they were able to stratify these sorts of prevalence measures by occupation and other important variables that may have been influencing whether someone was at risk of infection. Everybody in the field has been quite aware of the challenges of getting such detailed data in the United States. And I'm going to argue in favor of the need to try to do better at that. But in the meanwhile, there are also alternative approaches that can supplement what we learn from our somewhat haphazard system of case reporting in the United States to enhance our understanding. And throughout what I'm going to say, I think the theme of combining different data sources to create an overall picture is a common theme. So in 2021, Michael Mina led an effort to develop this method using viral loads, or CT values, which allows what seems like it should be impossible. It allows one to estimate from a single cross-section of viral samples whether the epidemic is increasing or decreasing. And the reason that it works is that in COVID-19 infected individuals, viral load goes up very steeply and comes down very slowly. And so in a growing epidemic, most people have been infected recently. That's what it means for the epidemic to be growing. There are more new infections than there were infections in the past. And so there will be a lot more high viral loads if you take a cross-section than in a shrinking epidemic in which more of the infections are old and therefore lower viral loads. And by developing a statistical filter to apply to viral load distributions, it was possible to calibrate whether the epidemic was growing or declining in several data sets. And so this is an example of using technology and methodology to compensate for limitations in our surveillance systems. And while I very strongly advocate improving those systems, I think we should also be pushing on other fronts, like extracting more data from what we have, more evidence from what we have. I am not alone in the view that that real random samples of the population to estimate viral prevalence and seroprevalence are really the gold standard. Natalie Dean wrote this very nice piece in Nature making that argument some months ago. And it's really the gold standard for understanding burden of disease in as it changes over time, and for many other purposes. I mentioned that Luxembourg had done that, and I got a little bit involved with them because I thought it would be interesting to see what a country with a small population and relatively high amount of resources would do. And they, in fact, did what has been the gold standard. But not only a small country can do it. The UK did the same thing. And in fact, when they saw what was coming in the late winter of 2020, they quickly set up two very large-scale studies with different designs to sample their population in a way that approached a random sample. One called UK React was a serial cross-section of different people each month. And the other was the Office of National Statistics COVID infection survey, which took households and sampled them repeatedly over time on, again, about a monthly basis. This produced a quality of surveillance data that was unmatched really anywhere else in the world. And in talking with colleagues who do infectious disease modeling, those of us in the United States, when we were trying to confront our models with data, were stuck using case counts and hospitalizations and other more delayed measures. UK modelers who were trying to project the course of the epidemic almost never used case counts because they had these two surveys which gave much higher quality and more comparable estimates. As a result, they were of these two surveys, they were able to estimate prevalence of infection and therefore estimate incidence, not only for the country as a whole, but for individual counties, which are sort of similar to states, a little smaller between our counties and our states and in size in the UK. They were able to estimate the cumulative incidence because they did sero surveys at the same time. They were able to detect and measure the rate of spread of new variants because they sequenced what came out of these surveys. They were able to estimate vaccine effectiveness as it depended on many factors in an observational and ongoing way that was free of many of the biases of some of the other designs that one can use. They were able to look at the symptom profile and how that evolved through time by asking questions of the people participating about their level of symptoms. They were able to look for evidence of reinfection or protection from reinfection. They were importantly able to look at health equity measures to compare across groups and understand to what extent the ethnic disparities, which unfortunately there were similar to the ones in the United States, or have been similar to the ones in the United States, that non-white ethnicities had higher rates of all the bad outcomes. But they were able to trace that back and measure the extent to which those disparities were due to higher rates of infection as opposed to differences in healthcare access or other factors. So if you care about health equity, random samples of the population are really valuable. And finally, they were able to estimate the infection fatality rate by linking to death data. Once again, in the sort of back and forth between what is the gold standard and what we should be aiming for, and what are some ingenious ways to do almost as well or accomplish some of the same goals, I think it's important to try to do both. This paper from a clinical investigator in Indiana and a statistician at Columbia suggested that a quasi-random sample of individuals could be achieved by using people entering hospitals for reasons other than COVID-19 symptoms in order to figure out the prevalence of infection among those individuals, and then use survey weights to adjust for the fact that, of course, the people entering hospital are different from the general population. So I think this is an appealing approach in a more limited resource setting, but it's not as good as a true random sample in my view. Although they make an interesting argument for why it might be better, and I encourage you to look at their paper. So when we think about these different types of surveillance and purposes for surveillance, I'd suggest that we actually think almost as we do for drugs or vaccines in terms of a target product profile. What is the system designed to do, and what do we need it? What do its features need to be? And I won't go through all the different columns and rows here, but the point of this table is that for certain purposes, we really need size and geographic scale. For other purposes, we really need representativeness, and for other purposes, we really don't need any of those. We really need to focus on the depth of and quality of the data. So the purpose of pointing that out is that as we're designing things, there are going to be budget trade-offs. As we're designing surveillance approaches, there are going to be budget trade-offs. And we want to focus on, for each purpose, the aspects that are most important, and on making sure that we have some way of doing each of these different activities. This slide represents the way I and I think many colleagues thought about the challenge of characterizing a pandemic prior to this one. And that is that there were certain things that are kind of relatively fixed, which are on the left, and certain things that are intrinsically changing every day, which are on the right. And that surveillance is basically the goal of surveillance is basically to keep track of the things on the right, and that the things on the left, like the virus sequence, the clinical severity, the kinetics, the contagiousness, and so forth, are things that you measure once and maybe measure twice, and you generalize from one place and time to another, and don't have to keep doing them. COVID has sort of upended that view, in part because the first thing on the left, virus sequence, has been changing repeatedly over the course of the pandemic, making it in some senses really a series of mini pandemics. Some of them not so many, rather than a single event. As a consequence of changing viral sequence and changing host immune status, these other characteristics are no longer things that we can sort of measure once and then think we know, but rather they're things that we have to measure repeatedly, and that we have to think of, therefore, as being surveillance targets, where surveillance is measuring changing quantities about a disease in order to track them and understand their consequences. And in red, I've written here the value of integrated health systems, and that's a little bit of a preview of the second part of what I want to say. So to conclude the first part, surveillance is really best thought of, in my view, as multiple specific activities with different scientific questions and therefore different requirements. And that we should focus on meeting those requirements for each activity and then think about ways that we can reduce costs by not oversizing or over specifying our efforts. And then finally, that COVID has expanded, in my view, the remit of research to include monitoring all those quantities that we used to call research. And I'll talk really in the next part about what I mean by that. So in this part of the talk, I'm going to describe some activities that I undertook back back before starting at CDC, and then one or two more recently since coming to CDC, working with different integrated health systems that allow remarkably detailed estimates of some of these quantities that I just mentioned. And the reason why they do allow such detailed estimates is because of the existence of longitudinal data, which allows matching of cohorts to create emulate randomized trials. It allows subgroup analysis. It allows detailed follow-up of individuals as they transition from outpatient to inpatient, and several other benefits. I've observed that many of the platforms that exist, especially in the US, for trying to measure some of these quantities are really focused on one or two of them, such as vaccine effectiveness, sometimes completely separate from vaccine safety. But I think it's worth noting, particularly as we try to find cost-effective and efficient ways of using data, that almost the same kinds of data can be used to answer a number of other questions, such as sequelae, severity, length of stay, and so forth. And that we should, as a public health system, work hard to extract the most value from these kinds of platforms. So as the first set of examples, I want to describe work that was done in Israel with the Clalit Research Institute, which is the research arm of Clalit Healthcare, the largest health maintenance organization in Israel, which serves about a little over half the Israeli population, so about 5.4, as I recall, million Israelis are enrolled. Every Israeli is enrolled in one of four, and this is the biggest of them. So the first activity we undertook after the vaccine was rolled out in Israel and in the US was to work with Clalit to estimate the protection offered by the vaccine against not only symptomatic illness, which was what the randomized trial had measured, but also hospitalization and severe outcomes, as well as COVID-19 deaths. And because of the near 600,000 individuals in each arm, compared to the 30,000 or so in the trial, it was possible to measure much rarer events, the impact of the vaccine on much rarer events and in subgroups. So the approach in that study was, as I mentioned, a matched cohort design set up to emulate a randomized trial, but in a larger population than would have been practical for a randomized trial. The emulation was possible because to approximate a randomized trial, you need to have balance in the risk between the two arms. Apart from the intervention you're studying, you want the two arms to be balanced in terms of their risk of the outcome. And so to do so, the colleagues matched on this large number of covariates, which were part of their existing database. To enhance that effort, we also used a negative control outcome. A negative control outcome is an outcome that we expect not to be affected by the intervention being studied, and is a way of checking whether effects that you do see on the outcomes where you are expecting an effect are likely to be due to confounding that's not adequately addressed, or to really the effect of the intervention. The randomized trial had shown that in the first 12 days after the first dose, there was no reduction in the risk of COVID-19 disease because the vaccine had not yet taken effect. We were able to use that in the observational setting to assess the adequacy of matching. And in this design, individuals who had been unexposed could become exposed when vaccinated, so they could contribute to both arms of the analysis. So doing this allowed us to assess, as I mentioned, the protection in subgroups, such as those over 70 years of age, those with 1 or 2 coexisting conditions, and those with 3 or more coexisting conditions, and show high, but perhaps slightly lower effectiveness in those with the most coexisting conditions. And then, as I said, we were able to assess the adequacy of matching by showing that in the first 12 days after vaccination, there was almost no divergence between the 2 groups, suggesting that they did not have intrinsically different risks due to differences between those who chose to get the vaccine early and those who didn't choose to get it early. And we found also that matching only on age and sex, which would be more conventionally available in less detailed data sets, did not fully control confounding, so that there was a divergence already within a few days of the vaccine being administered, suggesting that if you used this more limited matching, you were measuring a combination of a confounded effect and a real effect. We also moved on with colleagues to look at the sequelae of COVID-19 infection and compare them to the sequelae or complications of vaccination. So a vaccine safety study combined with a COVID infection sequelae study. These were the major results, showing in orange the risk difference for individuals who got versus did not get COVID-19. And in blue, the risk difference for individuals who got versus did not get the Pfizer-BioNTech vaccine. And you see that for most of the outcomes, the risk difference was much higher following vaccination than following infection than vaccination, except for lymphadenopathy, an expected minor side effect of vaccination, but a rare side effect of or a rare effect of infection. My favorite of the studies with Clalit, because I'm interested in transmission, was this study that showed the impact of vaccinating parents on the risk of infection in their children. Those children were too young to be eligible at the time, and you could see a direct effect on the parents, a reduction in the infectiousness of the parents if they did become infected, and an overall effect of protecting the children by vaccinating the parents. A second set of work was done in this country, again, before starting with CDC. And this was looking at sequelae of infection with a large database from United Health. Again, this was done by a matched cohort analysis, a little bit different in details of those who were documented infected with COVID-19 versus either contemporaneous comparators, year ago comparators to assess differences in healthcare utilization, and comparators who had viral lower respiratory infections that were not COVID, in order to see how COVID was similar to or different from other such infections. The sample size was around 260,000 for the exposed individuals. And the question was, we were measuring new events following diagnosis, but focused on the period on new events in the period 21 days post-diagnosis. This is an analytic choice that we changed in our second analysis, which I'll mention. But I think the details of the analysis are probably less relevant than the point that one can use these kinds of electronic health records to assess and billing records, electronic health records to assess the clinical sequelae that are that happen in the 4 months following the acute period of 21 days. The risk of any one of these happening was about 5 per 100 higher in those with COVID than those who didn't have COVID. And we could see differences for different outcomes between whether, as on the left with hypercoagulability, COVID was not only bad for you, but worse for you than another viral lower respiratory infection shown in blue. And on the right, the risk of cardiomyopathy was almost exactly typical for a lower respiratory tract infection, viral lower respiratory infection. And COVID was much worse than the comparators, but very similar to a sort of alternative respiratory infection. And we looked at subgroups by hospitalization. I just want to mention also that we then repeated this approach with a slightly different strategy looking at Medicare. And here we looked at sequelae that occurred 21 days or more after the index date, regardless of whether it had already occurred in the acute phase. So we thought that was actually a better way of defining the post-acute sequelae. Oops, sorry. And in this case, we're able again to quantify the risk difference or the excess risk of these complications persisting post 21 days after the infection, and see that they were, as one might expect, often more severe or more common in those of older age and those who were hospitalized with their COVID infection. Last example I want to give to allow a little bit of time for conversation is this work that was done at the beginning of this year, end of last year, beginning of this year, with colleagues at Kaiser Southern California and the University of California at Berkeley through an arrangement with CDC. In November of last year, the world was watching Southern Africa experience the Omicron surge and anticipating a similar surge in the US and other parts of the world. What was unclear at that time was how severe each case was going to be and whether the number of cases would translate, as it had with Delta, into quite a large number of hospitalizations and other severe outcomes per case, or whether it might be somewhat milder. Over a period of about a month, from the 3rd of December to the 11th of January, we worked together very rapidly, and we, mostly being Kaiser and Joe, worked together very rapidly to put together a first analysis of this of these data, which were a comparison of individuals who were ascertained in an outpatient setting with COVID-19, comparing Delta versus BA1, the early version of Omicron, and then subsequently repeating the analysis comparing BA1 versus BA2. We had the advantage that the Kaiser Southern California was heavily using the Thermo Fisher TaqPath device, which was capable of distinguishing Delta from Omicron based on S gene target failure without a need for sequencing. And that turned out to be crucial because systematic sequencing was not possible on the scale that one would have needed to do these analyses. What that analysis showed was that the risk of hospital admission was about 40% lower, the risk of ICU admission about 50% lower, and the risk of mortality about 80% lower for Delta than for Omicron. Sorry, for Omicron than for Delta, case for case, a diagnosed case for diagnosed case. And that on the other hand, the two subtypes of Omicron, BA1 and BA2, were entirely comparable to one another. It also allowed an assessment of the length of stay among these individuals and showed that it was shorter for Omicron than for Delta, but similar for BA1 and BA2. The ability to do that work relatively quickly depended on at least five or six forms of good luck. There was a lot of BA1 early on in Southern California, so it was there to study. There was a payer provider with a deep electronic health record and linkage to a vaccine registry so that you could adjust for that in the analysis. They were also linked up with a high quality analyst. They happened to be using a machine that could distinguish BA1 from Delta. And there happened to be a CDC contract that was allowed us to move money to get the work done. In my work in our work at the Center for Forecasting and Outbreak Analytics, we are very interested in trying to harden this kind of capacity and have been talking with a number of providers, including some who are currently working with FDA, and we'd love to learn more about that, about ways of making this kind of success repeatable, so that it doesn't rely on so much serendipity. One of the components of that we didn't need this time because of some of the good luck, but will in general need, is to be able to link in large numbers viral sequence data to clinical outcome data. This is something that I've been enthusiastic about for at least 8 years since writing this review article with a colleague, and that still is unfortunately much less common here than it is in some other places. So rather than read my conclusion slide, I think I will stop there and thank my colleagues who I've had a lot of time to think about these ideas with and develop them with, as well as some funders. And I'll stop and take some questions. Thank you.
Marc, that was amazing. Thank you so much. I could barely tweet to keep up with all of the highlights that you've provided. I might be guilty of the pop-up on your screen. I'm going to give you, I think, an easy one. There's a couple in the chat we'll pull up as well, but I think this is a great, maybe since you didn't say all your conclusions, ahead of time, one of our colleagues from Optum, Grace Yang, asked, where do you see the largest opportunities for interagency collaboration for public health surveillance and disease outbreak preparedness? Feel free to wear whichever hat you'd like and take on and off, but I thought that might be an interesting one to start with since you alluded, you didn't read all your conclusion points.
Right. Thanks, Grace, and nice to hear from you. I think that in terms of interagency within the US government, if that's the question, I think that vaccines are clearly one of the areas where there's interest from almost all the public health parts of the US Public Health Service on safety and effectiveness. And I think that that is clearly an area of great interest. And the other piece I would say is the thing that I ended on, which is that we really need to build the capacity to join sequence data with clinical data so that we can know from the sequence side, if we see a variant somewhere, is it a threat of infection, or is it also a threat of severe outcomes, or both? And then from the clinical side, we want to be able to stratify the knowledge that we have of severity and sequelae and kinetics and all the things that we have to measure as epidemiologists. Those are changing, and measuring it for one variant is not the same as measuring it for another, but we have to know which variants we're dealing with.
Well, excellent. I see our colleague George Ripsack would like to ask some questions. I'm going to tee it over to him. Hopefully he can unmute himself.
Can you hear me?
Yes.
Yes, we can.
Hi there. Thank you so much for the talk, Marc. I love the slides, and I was actually chatting back and forth. I had a particular comment on the vaccine effectiveness study. Anna Astropolitz, who's also on the call, published a paper in BMJ Open where she looked at the confounding that occurs with vaccination and found that it changed a lot after week 1 or week 2. Things like the people not showing up for COVID diagnosis because they thought it was a side effect of the vaccination. So things that are really short term that happened only there. And in her study of effectiveness, she showed a big difference in the first 7 days that was inappropriate, of course, from our knowledge of the truth, but fit the confounding. But then after that, exactly matched the RCTs. And that's why we did the chart reviews to figure out what was going wrong. And so I wonder, when I see an observational, an RCT, fine, but an observational research, when I don't see a difference in day one, I actually become more suspicious, not less suspicious.
Yeah, that's a great question. So I'd love to see the specific paper you're describing, because I don't think I've read it, but the World Health Organization had a number of calls with different groups that were seeing exactly that, often in a test negative setting or other types of study designs. And we asked ourselves why we weren't seeing the acute changes in rates that some others had seen. I believe that that part of it is that that the matching helped to remove some of the confounding as it was intended to. Also that we excluded from both arms individuals who had had contact with the healthcare system within the previous 3 days. So that, I think, helped to take away some of the healthy vaccinee effect, because at least acutely unhealthy people, or people with some knowledge that they needed to see a healthcare provider, were excluded also from the control group.
Okay, well, thank you. I'll send you the paper.
Thank you.
Just another note on the same topic. This is Anna, and who actually wrote the paper. So what interesting is that we also matched on the large number of covariates. So we sort of expected that this will balance the other baseline characteristics. But what we observed is that, in fact, patients who were vaccinated were not coming to the hospitals because they thought that these are the adverse events and not the infection itself. So we, in fact, did not really see the healthy vaccinee status or effect. We saw just the opposite, is that people were not coming to get tested, and this is why they were observed in the healthcare system with the infection later on after the vaccination. This is just a small comment.
Okay, yeah, I'd love to read the paper, and maybe we can have a conversation about it.
Sure, thanks.
Along these same lines, we have a question from Tracy in the Q&A chat. She's wondering, during the COVID pandemic, we had a lack of testing. So many people showed COVID symptoms and then died before confirming a positive COVID case. So we're curious about the case definition of COVID and if it needs a lab confirmation, and how we handle this when quantifying the burden of disease.
Yeah, it's a good question. So typically the definition of a COVID-associated death, it requires a positive test. I think that's true almost everywhere. That concern has been raised by many people in many different settings, especially those with limited testing capacity. So one approach that people have used, and I don't think there's a perfect approach, but one approach that people have used is to look at excess mortality, all-cause mortality compared to some baseline. And we did some work along those lines with Mauricio Santillana and others near the beginning of the US or of the pandemic for the US by state. And so that's one approach, or use of Yeah, so excess death type approaches is one way to get around that issue. We recently published a couple of weeks ago a study in several African countries using serologic data to try to estimate cases sorry, infections and compare those to reported cases. So that doesn't get to the death issue, but it used actually a study of autopsy testing of individuals for COVID-19 as one of the ways to triangulate. So this is another example where, particularly when you don't have a random sample that's ascertained in a knowable way, you have to triangulate different types of data.
Well, Mark, you've been in the hot seat for a whole hour, and I know there are lots of Q&A that have come through, and maybe the last one we'll try squeeze right in, which is around privacy preserving records linkage methods as a path forward for some of these data issues. Maybe if you have a 20-second soundbite of how you feel about that, we can certainly have folks reach out to you if they have questions after the fact.
Sure. Yeah, I think it's an important tool in the toolkit. My initial experience, but I am happy to be educated otherwise or see things change, is that is better for questions where you can wait a few weeks to a few months, actually more like a few months to get the answer. So for certain topics, it hasn't been used in a timely enough fashion. But I think that can get better. And for example, to link sequence data to clinical outcomes, it could be very promising. And some questions we don't need that super fast answer, so worth exploring.
Excellent. Well, we are so grateful we had you here. This has been such a wonderful presentation. And before we let you all leave, we just want to remind you that we do have another installment coming up. We have Tim Lash and Lindsay Collin, who are presenting on November 2nd. You can register for this. We'll share that with a link to the recording. Thank you again, Marc, for the time today. This has been so much fun. I'm sorry I have harassed you on Twitter, but we're not sorry. This was excellent. And we look forward to continuing the conversation and sharing some papers with you. Thanks again, and have a great rest of your day.
Thank you.